So for today's didactic, the topic is on strategies for reducing stigma in healthcare settings. And we have the wonderful Abby Frucci presenting for us today on the didactic for this very important topic. Abby is the Substance Use Response Coordinator for Community Caring Collaborative in Machias. She is a person living in long-term recovery herself from opioid use disorder. And her life and career are dedicated to engaging in county and statewide opioid and substance use response efforts. Abby has 9 years of experience practicing as a licensed substance abuse treatment provider in Washington County, and she specializes in treatment of those involved in the criminal justice system, which is very timely with all the work that's been happening for those in incarceration right now to get treatment services. She is also a member of the National Association of Drug Court Professionals and has devoted many hours of volunteer work at the community level on substance use prevention and recovery advocacy. And she's a lifelong resident of Washington County. Abby holds a bachelor's degree in human services management and is currently enrolled in the Masters of Social Work program through the University of Maine, Orono. And Abby, I'm going to turn it over to you. We do have your slides up on screen and we can advance those for you. I believe Jonathan has control of your slides. And I just want to thank you for presenting today, and we'll turn it over to you now.
Great, thank you, Kayla. I really appreciate that introduction. And can everyone hear me okay? Do I sound good? Okay,
yes,
great. And I always say that even within my experience working as a professional in the field, I think that the bulk of my strongest credentials come from being a person in recovery and my experiences of being a person in recovery and receiving services as a person in recovery. And so I'm going to draw from both my personal and my professional experiences when I share information with you today. So we can go ahead and advance to the next slide. So I just want to start out with this quote by William White. So William White is a author and recovery advocate who has been in the recovery scene for decades now. And he always has some very profound information and words that he shares. And so here it says, words have power. Words have immense power to wound or heal. The right words catalyze personal transformation and offers invitations to citizenship and community service. The wrong words stigmatize and disempower. And the reason why I chose this quote was two parts, because it talks about personal transformation and an invitation to engage when we're using the words that are not deficit-based and that invite people in, such as person-first words, but using the wrong words, which we'll talk about words being part of the conversation around stigma, although there's much more to this piece, but those lead to disempowerment. And I think there's such value in this, especially as we talk about the healthcare setting, because we're talking about people being in a position of power and people being in a position potentially of feeling disempowered. And so I just would like you to think about this as we go forward. Also, just keeping in mind that the words that we use, they stem from someplace, and we'll talk a little bit about that further on. The words that we use stem from our belief systems, stem from our experiences, stems from the thoughts that we have. So we really need to be aware of the words that we're using and start to think a bit about where are those coming from. Next slide. So let's talk about stigma. Everyone on the call here is working in substance use response and MAT services. This is a word that is regularly thrown around and that we discuss, but I think we need to really get to the bottom of what stigma is, because stigma is not simply the words that we use. And here, stigma has a couple of definitions, but here I have stigma defined as a social process which can reinforce relations of power and control. And again, I think this is so valuable to look at when there is stigma in healthcare settings. It really starts to create this power differential between the physician or just the staff of the healthcare setting and the individual that is seeking services. And we'll talk a little bit about how that actually can create barriers and significantly impact an individual's ability to access the services that they need. So we're looking at substance use disorder as a chronic health condition. And last month, for those of you that were on the call, Dr. Snyder really painted a great picture around how substance use disorder, like many other chronic health conditions, can lead to behaviors of non-compliance. However, substance use disorder is often not looked at as other chronic health conditions such as diabetes, heart conditions, and so forth, and more so looked at as maybe some call it a disease of choice. And so as we continue to educate ourselves and work towards building knowledge and understanding of what substance use disorder is, we also need to be very conscious about how we think about substance use disorder, how we're talking about it in our healthcare teams, and certainly how we're talking about it to the individuals that are impacted by it, as well as their family members and loved ones. So stigma here, we really identify it reduces an individual to nothing more than their difficulties. Stigma leads to stereotyping, and then it can move forward into discrimination. And so discrimination can often come about when stigma is just spread throughout different systems. Great examples of this can be when there is lack of access for individuals that need substance use services comparable to individuals that need other healthcare services, or when there are limitations for individuals with substance use services, or should I say, they're met with more punitive responses for their behaviors of the substance use disorder versus other chronic health conditions that may not be met with such punitive conditions. So again, it can lead systems to potentially withhold appropriate services, then could be viewed as discrimination. Also, it's very traumatic for individuals to experience stigma. The World Health Organization has identified that substance use disorder is the most stigmatized public health issue of our time. So when we look at the vast number of public health issues across the globe, we see that substance use disorder is viewed much differently on many, many different levels. And this can be by the individuals experiencing it. It can be viewed differently, as well as the individuals treating it. Next slide. So when we talk about stigma, we really need to look at bias. So we recognize that bias, that we all have a bias, and bias can really be looking at something either for or against based on our view of what that may be. It's either in favor of or against potentially a person or a group of people. Again, we all carry bias. I could have some good biases, maybe against processed foods that could be a benefit to my health. But certainly when we think of bias, oftentimes it's not in favor of. And so here, I've just put a couple of things to think about, because I always like to get people thinking about how they think of substance use disorder. Sometimes we don't openly talk about this. I think particularly in professional settings, because there's an expectation of how we're supposed to view it. But our biases can be impacted by our personal experiences, our personal belief systems, our education, our culture, and the like. So a couple of things just for you guys to think about as we get started here. So the first one is just what comes to mind, like what image pops into your mind, what sort of descriptors pop into your mind when you think of the word addict, when you hear that word addict, what sort of images? So just think about that for a minute. And then I want you to think about what comes to mind when you hear the word relapse. What sort of images might pop up? How might you, how might you view relapse, what that looks like for an individual or for the individuals that are around them? And next, I want you to think about what comes to mind when you think about, or maybe you can personally reflect on when you've had an experience in which you've encountered a woman that's carrying a child, a pregnant woman that might be engaged in active substance use. Just reflect on some of those thoughts that you may have had, some of the thoughts you may have now. And then think about that. Think about does the way that I think about this impact my engagement with the clients that come into my office? Because if I feel strongly about, for example, a woman, a pregnant woman who's carrying a child, if I feel strongly about that and about that being a choice, and I view that differently than maybe a male counterpart that comes into the office to receive substance use treatment services, how is my service being engaged, or how am I engaging with that individual? What are the words that I'm using? Am I being a bit more punitive, and am I offering the same level of support, or am I reacting differently? Also, there may be an emotional attachment here as well. We know that even as professionals in the field, we're often touched directly or indirectly just through our communities, and definitely through our work, by substance use disorder. And so is there any type of transference or countertransference happening in those relationships with my clients? And then lastly, as we think about recovery, I would just really encourage you to think about, how do you define recovery? I think we've come to learn that even across the healthcare setting, that we're not all speaking the same language. And it's very valuable that when our clients, our patients, are engaged in multiple services, whether it's behavioral health and clinical, and then medical services, are we speaking the same language, and are they hearing the same message? You can advance the slide. So SAMHSA defines recovery as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. What I found interesting about this definition, that sometimes varies from the definitions of recovery that I hear either within the recovery community or other professional communities, is that the definition of recovery does not include abstinence. And I believe that can be a misunderstanding or a misconception or bias that can be held among different practitioners, among different recovery groups themselves, and among individuals, that recovery equates to abstinence. I didn't add the slide here, but I want to take a moment to talk about it. Back in 2008, Faces and Voices of Recovery conducted some research and data collection around individuals' understanding of what recovery means, because it's really come to light that when we use the word recovery, not everyone understands what that means, or they may not perceive it and translate it the same way that the person using the word may be trying to translate it. And within that study, it was identified that 22% of the respondents had said that recovery means the individual is no longer using. But then 8% of the respondents had identified that recovery means a person's damaged. And then another 3% had identified that that means the individual has a mental health condition. And so what this says to me is just people's definition of recovery does not always align with the SAMHSA definition, and may not necessarily align with the definitions that we're using. And so when we look at how we can reduce stigma in a healthcare setting, we may want to look at, how do we define recovery in our healthcare setting? And are we defining it based on SAMHSA's definition, and is that a shared message that we're defining it the same way across the board? Next slide. Oh, one more click, Jonathan. There we go, great. So as I had said, stigma goes far beyond the words that we use. We've talked a great deal, and we talk a great deal about language, about using person-first language, which we'll certainly hit on a little bit more, about putting the individual before the condition or before the disease, recognizing that I'm Abby, and that means that I'm a mom, I'm a student, I'm a professional, I'm a peer, I'm a cook, all of these things, and that I'm not just a person with substance use disorder, I am a person. But when we look at our healthcare settings, we also want to look at, yes, are we using shared language? But also, how are we engaging with individuals that come to our practice? How am I greeting them? Um, are the receptionists or the individuals that are kind of the first encounter, are they getting the same training that our physicians and our practitioners are getting around stigma and around engagement? What are my body languages like? Am I smirking? Am I whispering when an individual comes in that may be under the influence or may appear disheveled or some other appearance that stands out? And so really looking at what are my behaviors and my responses. Am I engaging with them as I would engage with any patient that walks through into my practice? Also looking at the practice setting. What is the process? What is accessibility like? Is the process the same for an individual seeking substance use treatment as it is for my primary care patients? If an individual calls for an appointment, am I offering them an appointment in the same way that I would offer an individual with substance use disorder? Or are there additional barriers that may be a significant burden to them accessing these services? So really looking at our practice settings. Are we including individuals in recovery or that are impacted by substance use disorder into the development of our programs? Are they engaged in our conversations when we're asking, what do our services need to improve? What do individuals with substance use disorder need in order to be successful in our program? Are we engaging the recovery community to be part of those discussions? Do you have a member of the recovery community on your board? I know a couple of health centers that do intentionally have individuals in recovery sit on their board for that very reason. They want to make sure that they're inclusive and they're getting that information from lived experiences. This goes into your policies and procedures, as I've talked about. But I'd also like to point out, while I'm talking about patients, we also need to recognize that of the 23 million individuals in recovery and the other 22 impacted by substance use disorder, that the data tells us 69% of them are in the workplace. So it's likely that you may have an individual in the healthcare setting or in your workplace that is either impacted by substance use disorder or is a person in recovery. And are my policies and procedures of the setting, do they recognize that? Are the benefits, do I offer health insurance, for example, that covers substance use and behavioral health treatment for my staff as it covers medical services? So something else to keep in mind is we're not just necessarily talking about the patients that come into our practice. We've also talked a bit about the language already. We've touched on that. And it's interesting, a couple of things as I've done some research on stigma is one, how we also document our encounters. So there has been some research that um, focuses on documentation using real language that is stigmatizing and how that kind of can perpetuate the stigma if those records are transferred to another practice. So for an example, a physician of another practice will receive those records and review them. And if you're using language that is very deficit-based, very stigmatizing, then the research shows that that follows to this other practice that hasn't even seen the patient yet, and it can potentially impact the quality of care. I'd also like to point out under the practice settings piece, think about your waiting area. As I go into different offices and healthcare facilities, I often look around the waiting room, and I appreciate seeing information around support services and access to treatment services for a variety of medical needs. But I'm also looking for, is it just as accessible, the information around substance use and recovery-based services as well? So that's something that everyone can do today. Take a walk around your waiting room and just kind of look around and see, do I have information about recovery support groups, how an individual can access medication for substance use disorder, and do I have recovery resource guides, and so on. The last piece is really focused on the rejection of recovery pathways. There are as many recovery pathways as there are people. That's important to know. And so when we think about supporting individuals impacted by substance use disorder, we also have to think about supporting their autonomy to choose a recovery pathway. There have been times where I've engaged in conversations with individuals around stigma where they have felt very strongly that they don't have stigma, but then they move into uh, not being accepting of certain pathways of recovery. And so that's an important conversation for us to have, is are you supporting the individuals, just the autonomy for them to choose their personal pathway to recovery? And so as practitioners, that's something to keep in mind, particularly if it may be a pathway that's not offered through your service or through your practice. Are you providing information of where they can access that? Are you being critical of pathways that they've chosen? So on. Next slide. So stigma can have a significant impact on engagement with individuals. You know, some of the sessions we've talked about, just as far as with our case studies, engagement and being able to form trusting relationships. I've spent a lot of time interacting with individuals impacted by substance use disorder. And as an individual myself in recovery, the feeling of stigma or their feeling of being judged or patronized was often one that would limit engagement in services or with particular individuals if I felt that that was present. And so when we see stigma, often that can lead to just that, lack of engagement. Recovery is often viewed as connectedness, because substance use disorder and addiction really is about isolation. And when we're looking at engaging our patients, we want to build a welcoming and trusting relationship with them. Stigma can also lead to, as I was just saying, the feeling of being patronized, or again, kind of that power and control piece, feeling as though we're not being heard, or the individual is not being listened to, or their position is not being respected. Just as much, internalized shame can have a significant impact on an individual's ability to further engage in necessary services. That could be treatment services, it can be employment, it can be education. You know, it's really interesting when we hear the statistics around access to substance use disorder, that really only about 10 to 18%, the numbers differ, of individuals with substance use disorder access it. There's so many questions around why that is, and there's many reasons for why that is. But oftentimes, it's around some of that internalized shame. The individual feeling as though they're not worthy, they're going to be judged, regardless of if they've even stepped foot into the practice. That's what they're going to be coming in with, let alone what they may be met with at the door. That's why we really want to offer a practice that is free of that stigma and is very welcoming and engaging. Certainly, we know that discontinuation of services in this sense can ultimately lead to loss of life when an individual leaves our services. again, both that isolation of clients and staff. Remember what I had said, that 69% of individuals with substance use disorder are in the workforce. And so if we're using terminology, even if it's not in front of our patients, but it's within our practice setting, we don't always know how our staff and our coworkers are impacted by substance use disorder as well, and how that may lead to some isolation within your practice. Also, what the research tells us is even if that terminology is just used with among staff, it still perpetuates those real negative and deficit-based thoughts and feelings towards the population that you're serving. So, the gold standard is working towards changing your language and changing your practices, both with the patient and within the professional practice setting. And here, there's a saying here as far as if they don't care about their health, why should we? And vice versa. If an individual feels as though the physician doesn't care about their health, why should I care about it? So this is where some of that stigma may build and add to some of those altered beliefs that could put the patient as well as their services at risk. Next slide. So as I was saying, there's a lot of great research out there around stigma in healthcare settings, and I would encourage your practices to maybe do a little bit of research, or certainly I can send some of the information to you. Maine Quality Counts has a great handout on changing language in practice settings. But this piece of information that I found really focuses on the term abuser. And so as we've talked about language, this is one of the terms that we're looking at eliminating from our vocabulary. And I realize that this can be a difficult term to discontinue use from, because it still is part of some of the titles of our large overarching services, our national services and state services when we think about abuse. However, abuse has a very negative connotation. When you think about abuse, oftentimes, or abuser, oftentimes that term is linked to violent or very negative behaviors when we think about physical abuse or physical abuser. And also, what we see here is when individuals hear the term abuser, they view it much differently than if they use the term a person with substance use disorder. So if we look here, we see the white bars are substance abuser, and the black bars are substance use disorder. So of the population that was surveyed, it shows that a much smaller percentage should receive treatment if they are a substance abuser versus having substance use disorder. The population surveyed felt that they should not have access to treatment. However, a much larger percent felt that they should be punished. A substance abuser should be met with punishment versus a person with substance use disorder should not be punished. And we could see here about 70% versus about 25%. So more than double felt that a substance use abuser should be punished. Now, I just want to point out, whether you refer to me as a substance abuser or a person with substance use disorder, I'm still the same person. But you could see here, based on this surveying, that the perceptions are significantly different based on that term. As we go on through the graph, we see that the individuals surveyed believe that a substance abuser is a greater social threat than a person with substance use disorder. They attribute blame much, much greater, actually almost 80%, to an abuser versus a person with, which is about 25%. And a person with substance use disorder would be exonerated much greater than an abuser. And you can see here self-regulation. So while the terms are based on the same person, the beliefs are significantly different. These sort of surveys and research are really powerful because it just shows the impact that our language can have on the services, the community perception, the professional perception of the individuals that we're working with. Next slide. So here we've been talking about how stigma can impact practice settings, and also looking at what can we do. I really hope that each of you leave here looking at what can we do differently in our practice setting, or maybe you're checking the boxes to say we're doing that, which is excellent. We're already doing that work. And I know, at least for some of the FQHCs that I've been in contact with, that these efforts are well underway. And so this is excellent, excellent work. So the first thing that we can do is we can start to look at the language that we use and really look at the training for that. Are we providing training to all staff? I keep going back to this piece because oftentimes our professionals are receiving training for CEUs or CMEs, but are all staff from our receptionist or our administrative support through our clinical and medical staff, are they all receiving the same training around patient care and reducing stigma? Of course, patient-centered care focuses on respect, empathy, autonomy, transparency, empowerment, collaboration, and evidence-based approaches. So we strive for that as well in care for individuals with substance use disorder, right? We don't just strive for it for care of our patients that are coming to our practice for other chronic health conditions. We strive for that for all of our patients. Another piece that we can look at to reduce stigma in the practice setting is really doing a thorough assessment of practices from the top down, looking at policies and procedures as we've talked about, looking at our physical environment, looking at the processes, asking our patients. Sometimes that's a revelation when we think about, are we asking our patients that are impacted by substance use disorder what their experience is like? Are we open to hearing that feedback, and are we engaging them in that conversation? And also providing outlets for feedback for staff. This was an interesting piece that a CEO of a health center had brought up to me around really needing some safe spaces for staff to talk about this as well. We look at the changes that we're making to evolve and for best practices, and do we have outlets to process that, or some of the challenges that come with that, or as I'm grappling with my own personal biases, do I have safe places that I can talk about that? And so I would encourage all of you, as we wrap up the didactic for today, just to be thinking about what are the things that my practice is currently engaged in, what are some of the goals that I would like my practice to engage in, who are my community partners that can help with that. What are the internal partners? I think most practices have behavioral health professionals or strong partnerships with behavioral health professionals. Are we utilizing our internal capacity as well? Then again, of course, Maine Quality Counts, Qualidigm has some great information and handouts on approaches for healthcare practices to reduce stigma in their language in the healthcare setting.